Assalamu alaikum. Okay, now it's the time for endocrinology. In here, I will discuss the part by part of endocrinology topics, and we will go through the usmle inner circle notes. Start with my intro where we will hear a murmur. You can tell me in the comment box where what is the name of this murmur. Okay, okay. Now first, I would like to discuss about the pituitary problems. Okay, in pituitary there may be hyperpituitarism, there may be hypopituitarism. Hyperpituitarism regarding prolactinoma. Okay, in premenopausal woman, if a premenopausal woman comes with oligo or amenorrhea, there may be she has complaints of infertility. There may be galactorrhea, hot flashes, decreased bone density, looks like prolactinoma, and the postmenopausal woman may come with the mass effect like headache, like visual field defect, like headache, visual field defect, and men men come with big tumor because decreased libido, impotence, and gynecomastia usually decreased libido. These type of which are usually man's ignores and they come at the very last floor. So prolactinoma, bigger tumor found for men, bigger tumor, and smaller tumor found for female because they when there is oligomenorrhea or amenorrhea, the female straight go to the physician for evaluation, and that's how we can diagnose this prolactinoma. If we do labs, the prolactin level would be high, more than 200 nanogram per ml. We need to rule out the renal insufficiency like creatinine and hypothyroidism. So we need to rule out creatinine renal insufficiency, and we need to do the MRI of the head. And for treatment, dopamine agonist cabergoline can be given. Another dopamine agonist is bromocriptine. You can give bromocriptine also, bromocriptine, cabergoline. These are the drugs can be given, and the transphenyl surgery. If mild elevation due to prolactinoma, uh, mild elevation of the prolactinoma can be happen for plenty of causes like medication, like certain antipsychotics like risperidone. Risperidone is one of the drug. It can cause hyperprolactinemia. And nipple stimulation, pregnancy, hypothyroidism, and stress can cause hyper stress can cause prolactinoma. Mild elevation of the prolactin level can be found due to stress, due to nipple stimulation, due to pregnancy, due to hypothyroidism, and certain drugs. And high prolactin level more than 200 nanogram per ml is virtually diagnostic for prolactinoma. So more than 200 uh, is virtually diagnostic for prolactinoma. Okay, and you will be very astonished to hear that one of the psych disease like neuroleptic malignant syndrome, where the drug of choice is dopamine agonist like bromocriptine, dopamine agonist like bromocriptine, Krypton. In there are other options too. In neuroleptic malignancy, like bromocriptine can be given, dantrolene can be given if it is refractory, but dopamine agonist, cabergoline or bromocriptine for prolactinoma. Okay, next. Okay, if what is the management of hyperprolactinemia in premenopausal women? Hyperprolactinemia in premenopausal women. Detailed clinical evaluation like oligomenorrhea, amenorrhea, infertility evaluation, and rule out the secondary cause if she's pregnant or not. Then what you need to do, MRI, because if you don't evaluate this, like if somebody has pregnancy and you are doing MRI without knowing that she is pregnant, this is a crime. So MRI of the pituitary gland, if it is asymptomatic and microprolactinoma less than 10 millimeter, no treatment is needed. If it is macroprolactinoma more than 10, risk of neurologic symptom, hypogonadism and galacturia. Hypogonadism, galacturia. Then you need to give dopamine agonist, bromocriptine or cabergoline. Already I have discussed a lot about this. If there is persistent hyperprolactinemia, persistent symptom, no decrease in the tumor size, intolerance to medication, consider for surgical correction. So persistent hyperprolactinoma, persistent prolactin, persistent symptom, no decrease in tumor size, and intolerance to medication, it is then consider for surgical evaluation. What is the preferred image modality for evaluation of the pituitary tumor? This is MRI of the head. Recommendation for patient with elevated prolactin, mass symptoms, very low testosterone level, or disruption in other pituitary hormones. Okay, now I would like to talk about acromegaly. If you look at the features of the acromegaly first, there are local tumor effect, looks like features of the prolactinoma, headache. There may be headache. In acromegaly, there may be visual field defect, cranial nerve defect, and musculoskeletal is very common. Gigantism, frontal bruising, malocclusion of the jaw, macrognathia, arthritis, CTS. CTS has multiple causes. One of the causes is acromegaly. Another cause is rheumatoid arthritis and enlargement of the hands and the feet, skin thickening, hyperhidrosis, and cardiovascular like cardiomyopathy, hypertension, heart failure, respiratory sleep apnea, GIT, colon polyps or cancer, endocrine galacturia, hypogonadism, diabetes, and hypertriglyceridemia, and additional features like enlarged tongue, thyroid, salivary gland, liver, spleen, kidney, and prostate. What is our treatment of this? If clinical suspicion for acromegaly, then do insulin-like growth factor level, IGF-1 level. If it is normal, if IGF insulin-like growth factor level is normal, then it rules out the acromegaly. If IGF level is elevated, then do OGTT. If in OGTT there is adequate growth hormone suppression, again rule out acromegaly. If inadequate growth hormone suppression, do MRI of the brain. If in MRI of the brain there is pituitary mass, If in the MRI of the brain there is pituitary mass, then surgery versus medical management. Surgery versus medical management. If MRI of the brain show normal pituitary, evaluate for extra pituitary cause for acromegaly. Evaluate for extra pituitary cause for acromegaly like ectopic growth hormone release, ectopic growth hormone releasing secreting hormone, ectopic growth hormone releasing secreting hormone. So in case of acromegaly, first we do insulin-like growth factor 1 level. If it is normal, rules out. If it is elevated, then we will do OGTT. If in OGTT there is inadequate suppression, then we will go for MRI of brain or MRI of the head, you can say. Okay. The general rule of endocrinology is imaging is performed after biochemical diagnosis a disorder is made. Okay, now the posterior pituitary disease, SIADH. In SIADH, you have to remember CNS, drugs, lungs, cancer, CNS, drugs, lungs, and cancer, CNS disturbance, stroke, hemorrhage, trauma, drugs like carbamazepine, SSRI, NSAID, carbamazepine, SSRI, and NSAIDs, carbamazepine, SSRI, and NSAID. Can you tell me the antagonist of serotonin syndrome? It is cipro, sorry, it is ciproheptadine. When there is serotonin syndrome, the drug of choice is ciproheptadine. The drug of choice is ciproheptadine. You can give other drugs to, like you can give benzos, but ciproheptadine is the absolute antagonist. CNS drugs, now the lungs, pneumonia, and the cancer, small cell lung cancer, lungs for pneumonia, and cancer, a small cell lung cancer. Mild hyponatremia, just nausea, forgetfulness. Severe hyponatremia, seizures and coma. And euvolemia, moist mucous membrane, no edema, no JVD. And for SIADH, fast sodium is low, hyponatremia, serum osmolarity is low, less than 275. But urine osmolarity is high, more than 100, and urine sodium is high, more than 40, more than 40, more than 40. So in SIADH, urine sodium, S for SIADH, S for sodium. Sodium is low, serum osmolarity is low, and inappropriate. That means urine osmolarity is high and urine sodium is high. So you can remember via these tactics. And the management is fluid restriction and salt tablet. And you can give hypertonic solution if there is severe hyponatremia. These are the stimuli for secretion of the SIADH. Osmotic, if serum osmolarity is more than 285 milliosmol per kg, it causes stimuli for secretion of the SIADH and nausea, pain, hypertension, hypovolemia, hypoxia, hypoglycemia. Intranetal desmopressin can use in diabetic insipidus cause secondary SIADH. So intranetal desmopressin Use for diabetic insipidus for central diabetic insipidus can cause secondary SIADH. Okay, the hypopituitarism, primary polydipsia, central diabetes insipidus in nephrogenic diabetes insipidus. Primary polydipsia is increased water intake. Central is decreased ADH for release from the pituitary, and nephrogenic is ADH resistance. Primary polydipsia may be drugs, maybe anxious, middle-aged woman, and in here there is low serum sodium. In here there is low serum sodium. And in central diabetes insipidus, there is decreased ADH from the pituitary, idiopathic trauma, pituitary surgery, idiopathic trauma, pituitary surgery, and ischemic encephalopathy. There may be high serum sodium, and in nephrogenic, normal serum sodium. And for nephrogenic diabetes insipidus, it is ADH resistance in the kidney. It may be due to chronic lithium use, hypercalcemia, and hereditary chronic lithium use, hypercalcemia, and hereditary. There is normal serum sodium. When serum sodium is less than 137 with dilute urine, favors for serum sodium is less than 137 with dilute urine, favors for primary polydipsia and excludes diabetes insipidus. Central diabetes insipidus has significant hypernatremia, more than 150 due to an impaired thirst mechanism. Patients with nephrogenic diabetes insipidus with intact thirst mechanism, adequate water intake, they usually compensate for renal water loss and may have normal serum sodium level. Okay, evaluation of suspected polyuria. 24-hour urine collection. If urine output is more than 3 liter, it is polyuria present. If it is dilute urine, it is primary polydipsia. Water diuresis, primary polydipsia, diabetes insipidus. If it is concentrated, that means osmotic diuresis, increase solid excretion, glucose, urea, and saline. Concentrated urine, osmotic diuresis, increase solid excretion. If urine output is less than 3 liter, no true polyuria, work up for urine frequency. If it is dilute urine, water diuresis, primary polydipsia, and diabetes insipidus. If it is concentrated urine, it is osmotic diuresis, increased solid excretion, glucose, urea, saline. Low urine osmolarity less than 1.006, diabetes insipidus. High urine osmolarity and specific gravity more than 1.006, it is DM. So less than 1.006 is DI. Low urine osmolarity and low specific gravity, and high urine osmolarity and high specific gravity is DM. These are the features of the clinical features of the hypothyroidism. Pituitary cause, hypothalamic cause. Pituitary cause, it is a primary adenoma or metastatic mass infiltration like hemochromatosis, lymphocytic histiocytosis. It can cause hypopituitarism and hemorrhage or infarction, hemorrhage, pituitary apoplexia, or Sheehan syndrome. And hypothalamic cause mass lesion, radiation therapy, infiltration, mass lesion, radiation therapy, infiltration, trauma to skull base, and infection. And clinical presentation is ACTH deficiency, secondary adrenal insufficiency. There may be partial hypertension, tachycardia, fatigue, weight loss, hypoglycemia, eosinophilia. In ACTH deficiency, there may be second partial hypertension, tachycardia, fatigue, weight loss, hypoglycemia, eosinophilia. In hypothyroidism, there may be fatigue, cold, intolerance, constipation, dry skin, bradycardia, slowed deep tendon reflex, and for gonadotropins, women like amenorrhea and infertility, for men infertility and loss of libido. What is the likely diagnosis in a patient present with constipation, cold intolerance, low libido, hypoglycemia with eosinophilia? This looks like hypothyroidism, like constipation, cold intolerance, low libido, but hypoglycemia and eosinophilia for hypopituitarism. Patient is experiencing hypothyroidism, secondary adrenal insufficiency, and hypogonadotrophic hypogonadism. Eosinophilia is secondary to central adrenal insufficiency. Eosinophilia is secondary to central adrenal insufficiency. And we have to remember that aldosterone level should be normal. So just hypothyroidism feature, but there is hypoglycemia and eosinophilia. Think about what hypopituitarism. Okay, finally, in my video I have told you about my intro. Can you hear this murmur again? Okay, tell me the name of this murmur. It is aortic stenosis. Thank you. Please like my video and subscribe. Hope you enjoyed.